Alrighty, well, this is chapter 4 from the textbook of Radiographic Positioning and Related Anatomy, the 11th edition. This chapter has in it, it contains fingers, thumb, hand, wrist, and elbow. Fingers, thumb, hand, wrist, and elbow. So this particular lecture will cover the fingers, the thumb, I think it's fingers and thumb, forgive me, and the anatomy in the front of the chapter. So this begins on technically page 123. When we look at these upper limb structures, this particular picture comes from figure 4.1 on page 124. Basically, between chapters 4 and 5, we look at the entire upper extremity, going from the fingers, thumb, hand, wrist, forearm, elbow is chapter 4, and then humerus, shoulder girdle, clavicle, AC joints, and scapula is chapter 5. And we look at all of that plus lower extremity in this month course. When we look at the bones of the right hand and wrist, this actual picture comes from figure 4.2 on page 124. These are all terms that hopefully you remember from anatomy, proximal, middle, and distal. Each of those references each phalanx, which is a finger or a digit. Each phalanx has a proximal phalanx, a middle phalanx, and a distal phalanx, except for the thumb, which only has a proximal and a distal. So a phalanx, or a phalange, a phalange is the entire finger. So one phalange includes either proximal and distal phalanx, or a proximal, middle, and distal phalanx. They're always starting from thumb out. This is always referenced as first digit, second, third, fourth, and fifth. Each phalanx has a head, a body, and a base, just like each metacarpal has a head, a body, and a base. The carpals in the wrist, there are 8 in each wrist for 16 total. There are 5 metacarpals per hand, so 10 total. And then when we look at the phalanges, as far as the number of phalanx in each one, these 4 have 3, so that's 12, and then the thumb has 2, so there are 14 phalanx in the phalanges. When we look at the joints of the hand and wrist, this is figure 4.3 on 125. And typically we refer to in the thumb and the big toe, this is the interphalangeal joint, meaning between the proximal and the distal. Now proximal means closer to the point of attachment. Distal means farther from the point of attachment. So in between the proximal and distal phalanx of the first digit, or of the thumb, or of the first phalange, you only have an interphalangeal joint. We usually say an IP joint. In the others, where there is a proximal, a middle, and a distal phalanx, you have a PIP joint, which is your proximal interphalangeal joint, and you have a DIP joint, which is your distal interphalangeal joint. Between the proximal phalanx and the metacarpals, you have a metacarpal phalangeal joint. Between the carpals and the metacarpals, you have a carpo-metacarpal joint. You have intercarpal joints between the carpal bones on there, and this is pretty much the same for the hands, and or for the upper extremity. When we get to lower extremity, they're extremely close to that, except instead of metacarpals, we have metatarsals, and instead of carpal bones, we have tarsal bones, and there are only 7 in the foot. So once you learn the hand, I feel like learning the lower extremity is much easier to retain the information, especially after you know the joints of the hand and the wrist and the bones of the hand and the wrist. And I will always tell you that knowing your anatomy with regard to the bones is vital in our field. This image is similar to the one on page 125, figure 4.4. These all reference different areas. This would be, E would be the IP, the interphalangeal joint of the first digit of the right hand, because we always, if we can label right or left, we want to be able to do that first. So we would say right, then what digit or finger or phalange you're talking about. So if we're labeling E, we would say right, first, interphalangeal joint. If you were labeling G, you would say right, second, metacarpal phalangeal joint, and so on. So make sure you look at page 125 with that image. They have the review with all the radiographs, and you should be able to correlate anatomy to a radiograph, because that literally is what our entire job focuses on. The carpals, when you look at from the posterior or the dorsal, this is on page 126, figure 4.5, and we typically always start from medial. We start like in anatomical position. So typically from lateral to medial, meaning from first digit to 5th digit. The proximal row, you have the scaphoid, the lunate, the triquetrum, and the pisiform. And then in the distal row, you have the trapezium, the trapezoid, the capitate, and the hamate. Okay, so I don't see in this particular edition where they list the mnemonics, but they are coming. A lot of people talk about Steve left the party to take Carol home. There's quite a few for these. If you don't need a mnemonic, that's fine, but I would tell you, you should always be able to list the carpals starting from first digit through 5th digit, proximal row, and distal row. There are some significant things with each of these bone. The scaphoid bone, they tell you, is boat-shaped, B-O-A-T, boat-shaped. The lunate is moon-shaped. I'm trying to figure where they put these on here. Page 126, the scaphoid or the navicular. Typically the scaphoid is a boat-shaped bone. It is the largest in the proximal row, but not the largest overall. And it is the most frequently fractured carpal bone, is the scaphoid. The lunate is moon-shaped. It is in the second bone in the proximal row. The pisiform is actually kind of interesting. You really have a hard time seeing it, I feel like, unless the hand is in, if the hand is supinated, it's much easier to view that. We do a specialty view of the wrist where the pisiform is isolated, and it's really obvious. In the distal row, you have the trapezium, the trapezoid. The capitate is actually the largest carpal bone. And then the last one, you have the hamate, and that has a significant hook. There's a hook-like process on it called the hamulus. Okay, so those 8 in order from first to 5th, proximal followed by distal row, is extremely important. The anterior view, basically now you can see that you have the, this right here is the radius. Radius is always, thumb side always goes with the first digit. So this would be radius and this would be ulna. So this would be looking at it from the anterior view, which is figure 4.6 on page 126. Here's those mnemonics. Now they are not in the 11th edition, but Steve left the party to take Carol home is one. Send letter to Peter to tell him to come home is another. There's another one that I can't think of it right this second, but I will tell you when you're in class. And it's something about from thumb to pinky, and it helps make it make sense depending on which view you're looking at. It tends to click a little bit better. So I will tell you that once we are in class. As far as the joints, we looked at the joints before as far as what they're named, but typically the interphalangeal joints, you can have an interphalangeal joint between the proximal and distal phalanx in the first digit, and then you have a PIP joint, which is a proximal interphalangeal joint, so between the proximal and middle phalanx, and then your distal interphalangeal joint, or your dip joint, is between the middle and the distal phalanx. Okay, so when they say interphalangeal, they can either be truly interphalangeal or proximal or distal interphalangeal. This tells you the movement. So the first to the fifth metacarpal phalangeal joints have an ellipsoidal type of movement. Second to fifth carpo-metacarpal joints have a plane or a gliding movement, and so on through this. This actually correlates to, let me find this picture. This is on page 130, figure 4.21, that goes through the different types of actual joints with regard to movement. Some positioning considerations for the upper limb, and this is not necessarily in one spot in your book, but they do reference some of this on page 134. Starting on page 134, typically on the upper limb, you're at a 40-inch SID. You usually want four-sided collimation if at all possible. You always want the long axis of the part aligned to the long axis of the image receptor, meaning the long axis of the part, like if we're looking at her hand, the long axis of her hand is going with the long axis of the image receptor. So the length of what you're imaging goes with the length of the image receptor. That's an important concept. The side marker should be visible, and typically we place it lateral to the part being imaged. The easiest way to tell you that is that if it's a left part, the marker goes to the left of the part, and if it's a right part, the marker goes to the right of the part. Now, does it truly matter? No, as long as it's anatomically correct, it doesn't. But the radiologists prefer consistency and continuity, and that's the easiest way for me to teach you how to place the marker. And as always, you want to apply a radiation safety dose, meaning the highest possible kVp with the least amount of mass. Those are your considerations when you're positioning for the upper extremity. Some special patient applications. This also is on 134. With trauma patients, you want to make sure that the part is parallel to the image receptor. The central ray is at a 90-degree angle to the part and the image receptor, and that you are using correct central ray centering. A lot of times with trauma patients, they're coming in, they're either radiographed on the table or on the stretcher that they're on. A lot of times it can be a little bit overwhelming when you have a trauma patient, because it's just very chaotic in that situation. With pediatric patients, your biggest concern is motion. Speaking to them on their level, understanding that they're probably anxious or nervous, and speaking to them in a calm tone at their level can really go a long way. Geriatric patients, you want to provide clear, complete instructions, telling them what it is you need, what you need them to do for you, and the importance of holding still for that. As far as the exposure factors, typically with an upper extremity, you're in the 60 to 80 kVp range, especially with digital. You want the shortest possible exposure time. Small focal spot is vital, an adequate amount of mass. Okay, so with a correctly exposed image, you should be able to see soft tissue margins, you should see trabecular markings, and you should be able to see the marker. There should be adequate penetration. Typically, you are non-grid for everything up to the humerus. So fingers, thumb, hand, wrist, forearm, elbow, all non-grid, done tabletop. The routine positions versus special projections. Typically, when we talk about routine positions, you're talking about either an AP or a PA, an oblique, and a lateral. Typically, when you're talking about something that has a joint with it, you're usually doing 2 images at 90-degree angles along with at least 1 oblique. When you talk about special projections, those are things that demonstrate either specific or special anatomy, an axial view where you have an angle of 10 degrees or more, stress views where they're actually putting stress on the extremity, flexion and extension views are also common, and you typically have to angle the central ray or the part in order to achieve those images. Some digital imaging considerations on page 135. Collimation is vital. Not only does it reduce radiation dose to the patient, but it allows for your image, when it gets processed, to have the best possible quality. So you always want to collimate just beyond the area of interest. Always you would want accurate centering. The way that image plate is read, it's important that all imaging, that the anatomy, the central ray, be in the center of the IR, because it reads from the middle out. Grids typically are not used for parts that measure less than 10 centimeters. With direct digital radiography, sometimes they will use grids if it's integrated as part of the imaging system, but a lot of times it is not incorporated. They're put in as tabletop procedures or tabletop images, which is what they should be. As always, we should be looking at and evaluating the exposure indicator. Once you're looking at the image, you should critique it not only for proper anatomy, but also for an acceptable exposure indicator to verify that you didn't over or underexpose that patient for that particular image. Your exposure factors, ideally with digital, it is very forgiving. They have a wide exposure latitude, meaning that they can take an image that is severely under or overexposed and most likely make it appear acceptable. But even though it can do that, you still don't want to violate the ALARA principle or the image wisely or image gently principle. So you always want to use the highest possible kVp for appropriate penetration and the lowest possible mass to give you the best image quality with the least amount of dose to the patient. Some alternative modalities and procedures when we're looking at upper extremity, you could do arthrography, where they look at tendons, ligaments, joints. So typically with the wrist, the elbow, the shoulder, a lot of times they'll take contrast media and they'll inject it into the joint capsule to see what is going on, if there's any tear in the joint capsule. But arthrography is imaging of a joint, typically with contrast media. CT is also used along with MR. MR tends to show soft tissue better. And nuclear medicine could also be used to demonstrate osteomyelitis, any metastatic bone lesions, stress fractures, cellulitis. Typically, any of these four could also be used in conjunction with radiology to demonstrate different pathologies. The cast conversions, now these are actually on page 225 of your textbook. So if the patient has a cast, depending on the type of cast, because you're either typically going to have a plaster cast, which is a lot heavier and dense compared to a fiberglass cast. So if they have a small to medium dry plaster cast, you would increase 5 to 7 kV on your image. If they have a very large or a wet plaster cast, which is going to appear totally different than dry plaster, you would have to increase from 8 to 10 kV. And if they have a fiberglass cast, typically the increase is only about 3 to 4 kV. Notice I'm telling you though, with digital, typically you don't have to change your technique. But in order to be appropriate and what the registry will ask, this is the cast conversions that they're talking about. The two types would be plaster and fiberglass, and this is the amount of change required to bring about a diagnostic image based on those cast applications. The trauma terminology is in the back of the book in the trauma chapter, pages 576 to 580. They look at dislocation, subluxation, sprain, contusion, and then all the different types of fractures. All of these are vital. You typically have a lot of these written on your pathology sheet, and I would definitely make sure you understand the difference between a complete versus incomplete, a Barton's, a Bennett's, a Boxer's, a Colley's, a Smith's. All of these listed on the previous slide and this slide are vital for us to know, because a lot of times people think that fractures and breaks are two different things, that a break is a bigger deal and a fracture is just a small break, but that is not true. Break tends to be a lay term. Lay people use that. Fracture is specific to the type of break that is in that particular bone or whatever it happens to be. So all of these are found in those pages in the trauma chapter that were on the previous slide, and I would definitely make note of those and make sure that you're able to identify the difference between these types of fractures. On page 580 and 619, they talk about post-fracture reduction, meaning once the patient has a fracture, how do they fix that? So they could either have closed reduction, where they realign the pieces either by manipulating non-surgically. They use fluoroscopy a lot of times to be able to do that. It could be open reduction, where there's significant displacement of the fractured pieces. So they have to go to surgery and open the patient and repair that. And a lot of times if it's open reduction, they're going to have what's called ORIF, open reduction internal fixation. So if they have to use plates or screws or rods, that is considered open reduction with an internal fixator. Internal fixation, like we said, plates, screws, rods that are in the patient used to realign or reduce the fracture. If it's an external fixation, it means the device is outside the body, and that helps realign or reduce the fracture. So external fixators, sometimes you'll see people with like a metal contraption coming out of their arm. It might have screws or knobs. That would be an external fixator, versus when the hardware is inside the patient, it's considered internal fixation. As far as the fingers or the phalanges or the digits, all of those could be used synonymously, meaning you could x-ray the finger, you could x-ray a phalange, or you could x-ray a digit. So digits 2 through 5, meaning in lay terms index finger, middle finger, ring finger, and pinky, even though we would never call it that as an x-ray tech. Digits 2 through 5, the technique for that is 60 kVp at 0.8 mass. 0.8, not 8, less than 1. A PA finger, this is on page 138, and the central ray on a PA finger is to the PIP joint, the proximal interphalangeal joint, and they're showing you a PA image of the 4th digit and of the 2nd digit. So whatever is the digit of interest, your central ray would go at that particular finger or digit, the PIP joint, the proximal interphalangeal joint. So this is only digit 2, 3, 4, and 5. Thumb is completely different and separate. The evaluation criteria on this, you have to demonstrate the distal, middle, and proximal phalanx. You have to have 1/3 of the metacarpal demonstrated and all the joints associated with that. Central ray is at the proximal interphalangeal joint. There can be no rotation, and all the interphalangeal joints, proximal and distal, should appear open. So all of these joint spaces should appear open. Okay? So you are using 60 kVp at 0.8 mass for a PA finger. Then we have an oblique finger, which is on page 139. And if it's the 2nd digit, then you're doing a 45-degree medial oblique. If it's digits 3, 4, or 5, you're doing a 45-degree lateral oblique. So I always tell you guys that when you describe an oblique, especially with extremities, you first want to list the degree of rotation, and second is direction of rotation. So degree of rotation, direction. Always a degree and a direction when you're talking about obliques with regard to the extremity. When you're imaging the phalanges, the digit must be parallel to the IR in order to open the joint spaces. If the digit is not parallel to that image receptor, the joint spaces will appear closed. Just like on the PA, for the oblique, the central ray is to the proximal interphalangeal joint. So this particular image is figure 4.4, and notice that the hand is rolling medially or towards midline. And on this particular image, they're looking at, I don't know really what they're looking at, but on these, if they were looking at 3rd, 4th, or 5th, this particular one, they're looking at 3rd digit. So this has lateral rotation. Okay, so this one is medial rotation. This is 4.4. This one is 3rd digit with lateral rotation 4.41. This one is 4.42, and they are looking at the 5th digit is what they're telling you. So if the hand is rolling towards the middle, it's medial rotation. If it's rolling away from the middle, it's lateral rotation. 45 degrees for both. The evaluation criteria, you have to have the entire phalange and metacarpal phalangeal joint demonstrated. The interphalangeal and metacarpal phalangeal joints will appear open. If they're not, then the finger was not parallel to the IR. And the central ray is at the proximal interphalangeal joint. So these joint spaces do appear open, which means that the finger must have been parallel to the IR. The only issue with this is we don't know, based on the marker, what hand it would be, right or left. The lateral finger, that imaging is on page 140. And with the lateral finger, it's either a medial lateral or a lateral medial. That's going to be much better explained in person. But this image, this is the 2nd digit, and this is a medial lateral lateral. This is figure 4.45. How you would figure that out is put the patient in anatomic position, not literally, but I'm saying if you were to put yourself as the patient in anatomic position, the central ray is entering this side, which is the medial aspect of the 2nd digit, and it exits the lateral portion of the 2nd digit. So this would be a medial-lateral projection. This one, that is the 3rd digit, this would be a lateromedial, 4th digit, yes, lateromedial projection. This is 4th, lateromedial, 5th, lateromedial. Okay, so it's either a medial-lateral projection or a lateromedial projection. Again, the digit has to be parallel to the image receptor, and your central ray is to the proximal interphalangeal joint. You're going to demonstrate the entire phalange and metacarpal phalangeal joint. Central ray is at the proximal interphalangeal joint. It has to be in a true lateral, parallel to the IR so that the joint spaces are open. And you can see in this particular image they are using pen, a tongue depressor, something to hold that actual finger out. Because this is just like in the book figure 4.49, so this is the 4th digit, which has a hard time staying out by itself without the other fingers coming close to it. So that they would have taken a pen or a tongue depressor or something. You can see the way it's pushing on the skin to hold that finger out. Okay? So all fingers get a PA, all fingers get a lateral, and they all get an oblique, but it just depends if it's a 45-degree medial oblique or a 45-degree lateral oblique. And all of that information is found on your week 1 cheat sheet that was handed to you. Imaging the thumb or the 1st digit, the technique, it's still a finger, so it's still 60 at 0.8, but it has its own special positions for a thumb or a 1st digit. I would do them in this order, even though that doesn't follow the order in the book. So this is a PA 45-degree medial oblique thumb. That's what I would do first. And this is on page 142 of your textbook. And when you place your hand flat down on a surface, typically that will place the thumb in a perfect 45-degree angle. So when the hand is placed flat, typically the thumb will go in a 45-degree medial oblique. Okay? If you put your hand flat down on wherever you are, and you look, your thumb should be perfectly at a 45-degree oblique. Typically, this is a medial oblique, meaning, again, when you look at it, the thumb is rolling more towards midline versus away. And your central ray is to the first metacarpal phalangeal joint, because you have to include the first digit, the distal and proximal phalanx, the first metacarpal, and the trapezium has to be included in that. Okay, so the only way you can do that, if you were to center at the interphalangeal joint, you would clip. So we center at the metacarpal phalangeal joint, which is between the metacarpal and the proximal phalanx. So central ray is right here. This is a sesamoid bone, which is formed by friction. So we tend to have sesamoid bones in the thumb or the first digit. You also have them in the first digit of the foot or the big toe. Your patella is the largest sesamoid bone in the body, formed by friction, and typically it is formed when a baby is learning to crawl. The friction from them crawling forms the patella. If a baby never crawled, it would still form. It would just take a little bit longer, because even when they began walking, because some babies do walk and never crawl, so it would still form. It would just take a little bit longer in order for that to happen. So you have to demonstrate the entire thumb. The joint should be partially open, like in a 45-degree oblique. You must include the entire first metacarpal and the trapezium. That is pertinent anatomy. Central ray is at the first metacarpal phalangeal joint, and this, you can see soft tissue, you can see trabecular patterns in the bone, you can see a marker, even though that's annotated. That's the only hang up with that particular image. After you do your 45-degree medial oblique, I would then move to a lateral thumb, which is on page 143. You're at a 40-inch SID. Your collimation would be on all four sides just beyond the area of interest in order to fit your marker. You're 60 at 0.8, and you pretty much just take their hand from being flat down. You would I would tell them to curl their fingers up and then just put their thumb out in a lateral position. And your central ray again is to the first metacarpal phalangeal joint, and you still have to include the entire first metacarpal and the trapezium, along with the proximal and distal phalanx. And that still is 60 kVp at 0.8 mass. And the last view is probably the most challenging, and that is back on page 141. And protocol demands that we do an AP thumb, which is the figure at the bottom of 141, figure 4.51. So the hand, notice the hand is turned over in AP, just like if they were in anatomical position. The central ray is still to the first metacarpal phalangeal joint, and you still have to include the entire first metacarpal and the trapezium on this. So when you do that, the entire thumb gets demonstrated, first metacarpal, trapezium, your central ray doesn't change. It's at the first MCP joint, which if you notice is right where that little, on all of these, where the web of the thumb is, at that knuckle right where the web of the thumb is. You can see soft tissue, you can see trabecular patterns. The only thing we don't see is a marker, which would be a huge no-no, because the marker has to be imaged it cannot be annotated. Okay, so we want an AP thumb. If the patient is not able to do an AP thumb, the exception would be a PA thumb, but only if there was no way to accomplish AP. So this picture is on 141, it's figure 4.52, and it is only the exception because what the issue is there's increased OID between the thumb and the image receptor. Okay, notice too, there's no way that marker is going to come out on that image when it's over here. It's nowhere near the light field. The marker has got to be in the light field in order for it to be captured on your image receptor. So this scenario of doing it PA is only if they cannot possibly get their hand turned over to do an AP thumb. The evaluation criteria would, well, that's odd because that is totally not an an AP or a PA thumb. That is a lateral thumb. So I apologize for that. I don't know what they're looking at, but if you look at the figure 4.53 and 4.54 on page 141, that is what you should be visualizing. So not a lateral, which is this is wrong, but the one on page 141, that's what you want to see is distal phalanx, proximal phalanx, the entire first metacarpal, and the trapezium, and your central ray is at the first metacarpal phalangeal joint. So that little space where the webbing is in the thumb. I will fix that at some point and make sure that they get that image, or they won't make sure it's correct. I will replace it with the correct image. So I apologize. Specialty views of the thumb, typically in the extremity chapters, after the routine positions, there are some specialty images. So these begin on page, Modified Roberts is on page 144. I will tell you, we do not have time to necessarily play in the lab and position these. You're not comped on these in this course, but they definitely are on the registry and they love to hit the specialty views. So with the Modified Roberts method, the reason they would order this, if you look at the clinical indications on page 144, they tell you that it rules out a Bennett fracture. So it demonstrates fractures, dislocations, or pathologies of the base of the first metacarpal and the trapezium. So a Modified Roberts method rules out a Bennett's fracture, and the central ray is 15 degrees proximal to the first carpo-metacarpal joint. That image would look like this, which is figure 4.62 on page 144. The next specialty image is a PA stress view of the thumb, where you apply stress or force to a joint. This can also be referred to as the folio method projection. Okay, a PA stress projection is the folio method. So with that, when you look at this is similar to 4.64 on page 145. And what they're looking for on this particular image is any sprain or tear of the ulnar collateral ligament of the thumb. Typically, it results from hyperextension of the thumb, and they refer to this as skier's thumb, mainly because when skiers, like snow skiers, ski, they usually have their hands wrapped around the pole and their thumb on the top. And a lot of times when there is a fall or injury, because their hands are tied to that pole, the pole can actually push the thumb back and hyperextend it to where the thumb can actually touch the forearm, and it tears the ulnar collateral ligament. So you place a roll of tape between the two, you rubber band their thumbs, and when you go to expose, you tell them to pull as hard as they can to separate their thumbs. Notice how this one is straight and this one is bent. Okay. When that happens, when you bilaterally stress the thumbs and you're looking for that skier's thumb, what they do in 4.66, notice they reference that you demonstrate an ulnar collateral ligament tear on the left, because this is a 20-degree angle when it really should be closer to a 7-degree angle with the ulnar collateral ligament. You can see the roll of tape here. You can't see the rubber band, but we assume it was there. But the radiologists look at the ulnar collateral ligament and measure the angle of that, which determines if there is a tear in the ulnar collateral ligament. These are testable. So the modified Roberts, the Folio method definitely are testable. This is what you're looking at. That now, granted, we wouldn't necessarily measure this, the radiologist would, but when it tears, you get a larger angle in that metacarpophalangeal joint. The angle between it is greater versus when there's no tear, it is less. This one they're referencing 7 and 20 in the one that has a tear. So Folio method is a PA stress thumb projection. Modified Roberts method is another specialty view to rule out a Bennett fracture. And those two definitely are testable. And beyond that, notice the next page, they go into positioning of the hand. And that is a separate lecture, so make sure you go back through this, write down any questions or comments you might have with regard to the positioning. Again, anatomy is vital with this, as are all the different types of fractures and the open reduction, internal fixation, closed reduction. Anything mentioned in this lecture is considered to be vitally important to your understanding, and not only in class, but for passing of the registry. So any questions, bring them to class, and next time we meet, we will go over them. And I hope you guys have a great rest of your day.